Y'all, good morning, good afternoon, good noon, good everything. I hope you're having an absolutely fantastic day. And there is no doubt that you're going to make it even better by spending some time with us. Ordinarily, you know how we do this if you've been here. We give everybody some love. Uh, the scribe who is David today after a 24-hour shift. Anmol, who's doing teaching points and kindly subbing in last minute for another team member in true CP Solvers fashion. And of course, our beloved CEO and a CEO chair, Yusuf. Um, but today, really, is all for me about celebrating the singular human being that is Yaz. She doesn't need an introduction to VMR. We deliberately, I can't see her. Is she here? Oh my gosh, did she fall off? Do you guys see her? I'm on an unusual screen. She's not here to be made fun of. Oh no. Yusuf, do you see her? Or am I just
She's
hallucinating?
she's back now.
Okay, all right. Whew. Yaz, you're back? Yay,
Yes,
nay?
I am. I'm so sorry. Like something happened, but
Oh
I'm
my
gonna
gosh, I'm
use
so
this
glad I
again.
noticed. I was just telling everybody that the normal procedures is to have everybody open the mic and give them love. But today is all about you, my friend. We planned this strategically so that we'd be able to give you one last pre-intern year VMR, not farewell, but like parting gift, a transition in your life. And I got a little emotional thinking about the significance of today because I think what you have done in CP Solvers is unmatchable, and I think it's unmatchable not because of the intellectual brilliance that you've accumulated and developed in this space, but I think you have single-handedly developed such wonderful, rich personal connections with everybody, and have really showed us how to be a really, really good human being. And we all know just how hard you work to be able to hit the heights that it requires to match in internal medicine, and we're so very proud of you. And so I think, as I was telling Prof. Rez, that it would be you who would be discussing in his seat today. He's partying in Lisbon. Um, and by partying, it's the, like he would say, old man version of partying. So don't get creative with your imagination. Um, but we're so, so proud of you. Yeah, so proud of what you've accomplished. So excited for your future. And what better way than to make you sweat and anxious than by having to discuss a Yusuf case? So I'll hand the mic to you to say hello, and then we can jump right in.
Thank you
Hello,
very much,
everyone.
Maria. Oh, sorry. Uh, did you tell me, Robbie?
Yes. Who else? Oh
Oh,
my gosh, please.
sorry. It's because I didn't know if I had frozen, but you're gonna make me cry with your words. I'm really like I'm very thankful for this opportunity. I think that CP Solvers has meant so much for my career as a doctor. And I think that for many of you who just joined, or for lack of a better way to say it, just joined, I think that I just was following the example of a great IMG, Rafa Medina. And I think that he's always been like an example for me. But I really have to thank all of you because it really takes a village for one of us to thrive and to achieve our goals. So thank you very much.
All right, now we got the thanks out of the way. Now we'll cue in the sweats and the anxiety and the stress of solving a Yusuf case. Yusuf, hello.
Hello, everyone. It's gonna be great.
I love it. As brief as a CEO should be. Take it away, my friend.
Yes, despite all your kindness, I was not kind with this case. It's kind of a tough one, but you got this. So this is a case of encephalopathy. So a husband brought in his wife, who is 7 years old, for change in personality, and I'm gonna stop there.
All right, dear Yaz, what do you think?
Okay, so first of all, you're telling me that this is a person, a patient with changing personality. That's very interesting since I don't think I've ever discussed or heard discuss a change of personality. Normally, when I think about a change in someone's like mental baseline, I'm thinking AMS. But in this case, change of personality, the first thing that comes to my mind is this is abrupt or progressive. like, what is the time onset? Because for me, I would approach it in the way that if this is like sudden, from like yesterday to today, they started saying weird things. Like, what do they mean by changing personality? Did they start saying weird things? They were starting being aggressive, or like out of themselves. I think the age of this patient was 50 something, if I heard right. So before I jump to say a lot of diagnosis, the main things I will think is maybe an infection, maybe metabolic. There are well-defined buzzword infections like herpes encephalitis that present with like changes in like the personality, or drugs like PCP who make you like more aggressive. Oh, 70, sorry. But yeah, I think that the key here will be, what was the time onset for the change in personality, and what do they mean by that? What do you think, Rabih?
I saw Laura's already making fun of me for eating during this, but it's a ritual. I can't overcome it. But I'm right there with you, and I think Yaz, the most important thing you said was that this is not altered mental status. Altered mental status typically refers to a change in the patient's level of arousal. This is a focal neurological entity characterized by dysfunction, often in the cortex, either the frontal lobe or the temporal lobe, or sometimes in the basal ganglia. So how is it different than altered mental status? Because it is more likely to be a focal process, it is more likely to be in the brain itself rather than a diffuse process like hyponatremia causing a change in the level of arousal. And I think that's really, really key, because all altered mental status is a simple question. Is this an intrinsic brain problem, or is this something outside the brain going and affecting the brain in some way, shape, or form? And the presence of focality does not mean the problem definitely lives in the brain. It's possible that a systemic disease infiltrates the brain in an asymmetric way, but it certainly increases the probability that something will be found in the brain. And so from the get-go, we're still going to do the same workup for brain problems by querying what's happening outside the brain, but we have to, in parallel, be more vigorous about investigating intra-brain processes. And so let's see what Yusuf has in store for us.
So this is a 7-year-old female. She has a history of lupus on hydroxychloroquine. She also has a history of HFrEF or HF recovered EF, hypertension. She has had some cardiac complications in the past. She had like an AV block where a pacemaker was placed. And for the past month, the husband reports that she's become very much more distractible. Like she would be doing a task and then she would stop and get distracted. She's not having any sleep. She's not sleeping at all. He feels like she's very like pressured, has been walking around the house, and he feel like he can't take care of her anymore over the past month. She's been having a labile mood, has been crying here and there, has decreased PO intake. She also had a fall and hit her head once as well. And he's not able to pinpoint it, but he feels like this is all new. She's completely changed in the past like month. She has been reporting headaches in the past 6 months, but she has also had headaches all her life. But otherwise, that's all the subjective.
Wow, very, very interesting. Yeah, yes. What happened in your brain there? How did things change?
Well, now that he mentioned that, Joseph mentioned that this has been for months, let's say, I'm starting to think in this age group, try to see if there is, like any sign of dementia. So also, because of the way that you are describing that she has labile emotionality. I don't know how to say that. She has different like emotions, and she has been feeling disoriented. Maybe that fall could have been because of that. The first thing I would do is to do a neuroexam. That is my reflex. I also remember him mentioning something about he has she has vascular issues. So one of the things that I would like to see, because this is like sounds like a stepwise progression, will start a workup for vascular dementia. But again, I don't like just encasing the patient in that and that's it. I will also want to know how she is metabolically, try to run the CBC, CMP, as you mentioned, the lights to see if there is any like hyponatremia. Also, I'm wondering if she's on different drugs other than hydroxychloroquine, because that could also, like, if there are like any interactions, maybe that's what's happening with our patient. But that's the first thing I would do reflexively. I pass the mic to you, Ravi.
Yeah. Thank you for. I'm going to catch the mic as best as I can because it's a very hot mic. It's a very difficult case, and I'm just going to try to outline the tension that I'm feeling, Yaz, which is that she has a rich extra brain history, and that rich extra brain history includes lupus and includes having a pacemaker. And both those things can result in very serious brain problems. So there's a whole overlap of lupus plus neurological disease that includes direct complications called lupus psychosis or lupus catatonia, and includes indirect complications such as lupus-induced TTP or lupus-induced lupus-associated antiphospholipid antibody syndrome. So you can see how all those things can cause brain problems. The same is true for when a pacemaker gets infected and causes thromboembolic disease to her brain. And there's also rarely associations with hydroxychloroquine and all sorts of neurological issues and vision issues as well. So you can see that it's very compelling to look at her medical history and see that it's hard for any of her illnesses not to be related to such prominent systemic diseases. But what's interesting is her brain disease seems to be very, very focal. This is not somebody who's being brought in by their loved one because she's sleepy and hard to wake up. She's being brought in because very discrete issues that are either in her frontal lobe, temporal lobe, or her basal ganglia. This is not a diffuse encephalopathy. This is very, very characteristic. And then to ask, what do we make of the headache too? Does that signal that noise? So the tension is the following. She has strong HPI is very suggestive that there is something wrong within her brain itself. The medical history is suggestive that a systemic disease is at play. So how do we mix these two? Systemic diseases usually cause a global, non-focal, sedating encephalopathy. And that's the tension in this case. So my advice is we keep pursuing each thread separately. Investigate her lupus, investigate her pacemaker with blood testing and blood cultures, and investigate her focal deficits in parallel. And then we'll see, do they mix? Or are they like oil and water, that they're actually true and unrelated? And I think that'll be interesting to see. I know the case has a lot, so let's hand the mic to Yusuf to get a little bit more clarity, and I'm sure we'll have a lot to nerd about. Go for it, Yusuf.
Yeah,
What do you
excellent discussion. So she takes hydroxychloroquine, 300 milligrams. She's also on aspirin, metoprolol, medications for her heart, like an ARB and a spironolactone as well. Lives with her husband, does not smoke, drink, or use any substances. On initial vitals, she was afebrile. Her heart rate was within normal limits. Her respiratory rate was also within normal limits. She was slightly hypertensive. On exam, she was resting in bed, not in acute distress. She is oriented ×3, but she also has very pressured speech. She's able to repeat items after being told to her, but she's not able to recall like 3 objects after 5 minutes. She has like flight of ideas and is very tangential. On a physical exam, she had no murmurs and her strength was 5/5 throughout, and her reflexes were within normal limits. And I'll pause there.
Fascinating. All right, Yaz, you're up. You'll be doing neuro
so
exams all day. What are you thinking?
I'm going into neuro, and I am not the neuro expert here. I'm sure Vale, I are watching Gerardo might be watching this too. So after mentioning that this patient has this speech, she's not able to repeat recall objects, sorry, the reflex are normal. And your commentary about localizing these where the issue is, I think that so far I agree on considering this neuropsychiatric lupus, but I also thinking, what if this is a thrombotic event or an intracranial hemorrhage that has been slowly progressing? She has vascular issues, and even if she's on aspirin, I think that, if I'm not wrong, that can increase the intracranial hemorrhage. I see that she's on supplements, as Sarah mentioned also in the chat. I'm thinking, aside from try to put this in buckets and start to do the workup for each one, would be the neuropsychiatric lupus, this anything like cerebrovascular disease, specifically maybe an hemorrhage looking for a thrombotic event. This in the another bucket would be a medication effect for the hydroxychloroquine. And I would, as just as the back of my mind, consider that if I don't find anything, start digging for things more obscure in my opinion, look for amyloid angiopathy or a mass, or I don't know, something autoimmune. But in the meantime, those are my 3 buckets, just to see what could be the most probable thing she might be experimenting. And I don't know what you think, but as I see her issue with her speech, intact to naming and repeating, but not able to repeat objects, I will think there's something going on Bernique area, if I'm not wrong, because Brooke is the one that talks. Bernique is the one that processes. So,
yeah.
So help me.
You are set. You know, you're going to be an outstanding teacher. You know why? Because you use your hands so much to talk. It's like you're putting things in buckets and talking. Yusuf, one of Yusuf's mentors, Dr. Kimberly Manning, talks about the gesture box, about how really good teachers use their hands to create visuals in people's minds when you don't have a whiteboard. I can see you do that. And yeah, you're right. I think the categories and diseases that you're starting to latch onto is where I'm at. And I think so I have nothing to add about the diagnostic hypotheses. So I'll just share one advice on next steps, which is you almost everybody with an encephalopathy, unless you have a clear answer like severe pneumonia, you often have to image their brain. So a very practical question comes up about how you image their brain. And quite simply, you only have 2 tools, a CT and an MRI. And a CT scan is an excellent tool if your suspicion is high for an extra parenchymal issue like a subdural hemorrhage or a subarachnoid hemorrhage, or if you are suspecting a large asymmetric intraparenchymal issue such as a huge mass, or if you're suggesting the possibility of hydrocephalus. So, when radiologists write reports, they say no evidence of hemorrhage, herniation, or hydrocephalus, the 3 H's. So the question is, are we worried about hemorrhage in this person? No. Are we worried about herniation? No. Are we worried about hydrocephalus? No. So the yield on a CT scan for this patient is unlikely to be productive. So if an MRI were as easy and as fast as a CT scan, you would probably just get an MRI. The only issue with MRIs is they're cumbersome and a very, very hard to obtain resource, which is why you might get a CT before an MRI, but the MRI is likely going to be the most important. And so you might ask yourself, is it just MRI full stop? No, there are some nuances about when you get MRI with or without contrast. And if I were to take a moment to simplify that, the only time you should definitely just get without contrast is if you're worried about a stroke. You don't need contrast for stroke. But if you're worried about anything else but that, you often need contrast either to see inflammation in the form of a structural lesion that takes up contrast, or to see the contrast wash out and look for a dural sinus thrombosis. So my advice here is There is no evidence overtly of herniation, hydrocephalus, or hemorrhage. And since the probability of a stroke is not the most likely diagnosis right away, this patient will probably need an MRI with and without contrast unless we find a very obvious explanation on her labs. For example, if she has thrombocytopenia, hemolytic anemia, and schistocytes from her lupus, i.e. TTP, we may not need that high quality brain imaging, though you might just get a CT. So I have nothing to add to your hypotheses. That's how I would move the case forward, but let's see what Yusuf did.
Wonderful thoughts. So on initial CBC, she was anemic, but her hemoglobin was at baseline. Her chemistry panel was within normal limits, her mag, phos, calcium, all within normal limits. She did get a CT head in the ER, which was no acute intracranial abnormality. She got a UDS that was negative, got complement levels that were normal. Neurology and rheumatology were consulted. I was actually on the neurology team. I was rotating on neuro. So the neurology team recommended an MRI. So the MRI brain with and without contrast did not show any evidence of cerebritis or infection. And I'm going to pause here. If you want to do 2-minute breakout rooms, this might be a good spot as well.
I love it, Yusuf. By the way, just so this is a case from residency, huh? Incredible.
Yes.
I have to say that's really cool that you remember that and that you're bringing that here. And I'm taking for granted just the incredible quality of the presentation here because it doesn't surprise me at all, Yusuf. But I think we should just take a moment to thank you for digging this case out from the residency archives and bringing it here. I can tell it's a really really cool case, and for presenting it so clearly, and for the Nut to Do breakout rooms, which I'm about to do. So first, let me pause. All right, welcome back, everybody. Oh, wait, I don't see. Oh. 1 second. All right. Oh my gosh, my Zoom screen is really funky. I think everybody's back. Is that right? Yeah, there you go. All right, Yaz, where are you at? We lose Yaz.
Well, I have to shout out to Sarah. She had a very an amazing approach. She reminded the group here with Laura and Magnus that we should also consider frontotemporal dementia. We all agree of having a lumbar puncture, all this. They gave me a lot of feedback on how, what is the next step on the workup for this patient.
Yeah. I love it. So you're summarize. I'm sorry. I think my Zoom was a little glitchy. To summarize, I think you're thinking next step LP, and
yes.
then maybe a diagnosis after that is a dementia syndrome, and the dementia syndrome that fits best in a patient with behavioral changes, personality changes is frontotemporal dementia. I love that. I think that's very wise. Did I miss anything, Yaz?
No, not at all. But if I can mention
Please.
this patient, we also touched on the anemia, the slight anemia of this patient, and common things being common as we're talking in the breakout rooms will be assess the B12 folate levels, also the thyroid function test for everybody that's going to do the step 3. Always when you have an elderly patient, ask for a thyroid panel. And assess for inflammatory markers, and of course the LP, look for any infection, autoimmune markers, paraneoplastic antibodies and such. But those are the main steps for us.
Yeah, absolutely love it. So, I'm right there with you. I think I will try to share my thoughts from a very simplistic perspective, and just ask all of you to think about one question. Where is this disease? And I'm not being silly by saying that. I mean, if you did not tell me what the patient presented with, how would I, using her labs and her imaging, know? And the answer is I wouldn't. If you just told me, hey, can you guess what this person's problem is if I show you her labs and her MRI? Think about that. You have no idea what her problem is if you don't talk to her, and her problem isn't showing up at all on a comprehensive laboratory assessment and MRI. Now, you may be naturally, at first glance, disappointed that you haven't found a correlate to her symptom complex, but I will tell you that that is a profound clue. And essentially what Yaz is saying is maybe we should look in her CSF, and maybe that's where we'll find her disease. Lymphocytic pleocytosis with the low protein, maybe this is all cryptococcal meningoencephalitis. And that's a very, very wise disease. And so where are we at? We have a really good hypothesis that this is a disease in the brain. The question is, which compartment? Is it in the parenchyma? Is it in the vessels? Is it in the ventricles? Or is it in the meninges? And based on the MRI, it's not in the ventricles. Most vascular diseases show up on an MRI. 95% of vascular diseases, you'll see evidence of them on the MRI, as thrombi, aneurysms, so on and so forth. So either this is a meningeal disease for which the LP will be elucidating, or this is a subradiological parenchymal disease. The champion of subradiological parenchymal disease is antibody-mediated disease. The most notorious mimicker of subradiological disease is prion disease. Now, let me tell you why I said mimicker, because if I interpret her MRI, I will call it normal because I don't know what I'm looking at. Prion diseases are so subtle on MRI that you need experts to detect the subtle cortical and subcortical findings that CJD has. So if we're sticking to our master schema, she's either got a subradiological parenchymal disease or a meningeal disease. LP, next step, clear. The question is her MRI negative because I read it? And is it truly negative? So you always cannot move away from CJD until you've had the best neuroradiologist available to you. Make sure, and this is a common misstep, because we start to pivot towards true subradiological disease instead of entertaining subtle radiological diseases. So you don't want to miss CJD. It has dramatic consequences for patient morbidity. You'll waste your time giving the patient empiric immunosuppression, so on and so forth. So for what I would do, Yaz, is I would either repeat the MRI or make sure it's reviewed by the most skilled person available to us, get an LP. But here's another piece of advice, and sorry I'm talking so much, because this case is actually very complicated, and I want to arm you with as much as I can before you become very busy repleting potassium and inducing fixing healthcare-associated constipation, the core tasks of day one of intern year. How do we diagnose people? We diagnose them either by getting a blood test, an imaging test, or a biopsy. But we also diagnose them by response to treatment. And I will tell you that you have to think about catatonia here. In addition to antibodies being a notorious cause of subradiological parenchymal disease, as is catatonia, and unfortunately catatonia commonly complicates lupus-induced neuropsychiatric symptoms. So what is in my toolbox right now? LP, reassess MRI, serum and CSF antibody profile, and I would talk to psychiatry about assessing her and seeing if in their expert eyes and hands, a trial of benzodiazepine might be informative here. But I've said so much, Yaz, that maybe we can get more information to digest from you, Yusuf, and we'll see what you come up with.
Oh, excellent discussion. So psychiatry was consulted and then LP was performed. The CSF protein was normal, CSF white blood cell count was normal, and CSF glucose was normal. Psych evaluated the patient and they said that she's, I'm going to say what they wrote in their note. content disorganized, talking about quantum leap, very talkative, grandiose, delusional, no hallucinations, oriented to place and person and time, but not to situation, and no insight/judgment. They recommended that if this is mania, this is very, very abnormal for her to present at the age of 70, and that they recommend a workup for secondary causes, and in the interim to start aripiprazole as needed for like these symptoms. And I was gonna pause there, or if you want me to give you the next aliquot, I can also give the next aliquot.
Yeah, why don't you do that, Yusuf, just for the sake of time?
Okay, so other workup recommended by neurology, the TSH was within normal limits. The TPO antibodies were like elevated at 144. The autoimmune and paraneoplastic panels were sent. They had not resulted yet. The celiac serologies were within normal limits. We did get like a CT chest, abdomen, pelvis, which did not show any large masses or lymphadenopathy. There was a solid right lower lung nodule that was 5 millimeters. That was based on the Fleischner criteria. I just recommended follow up in 12 months. And we did do like a breast exam, which did not show any masses on exam as well. And I'll pause there.
Alrighty, is the sweating kicking in, Yaz, or not yet?
I already took off my Pataguchis. Of course I am.
I noticed.
Oh gosh. So the first thing that rang the bell was a TPO that's high.
Yeah, what does that mean for you?
So, for me, like, and feel free to correct me, I'm here to learn, is that one of the things that I would also consider, like knowing that TPO is high, would be Hashimoto's encephalopathy. I know that somebody, I think David wrote the I think it's SREE something. But
yeah,
that would be like the first thing that jumped out. Although there is normal CSF protein, I think that is not so needed for diagnosing Hashimoto's encephalopathy. Another thing that I see interestingly is that I would have expected something else in the LP, so honestly, but Yusuf, I don't know if he's like withholding more information about the CSF, but something that really scares me as a diagnosis is Creutzfeldt-Jakob disease, as you mentioned. So I don't know if there will be like 13-4 proteins, or you have to ask them aside as like an extra workup. But those are like the main two things that jump for me. Like, try to explore the area of Hashimoto's encephalopathy, something metabolic, or try to see if this could be maybe a medication-induced psychosis. Let's see how she does with aripiprazole.
Yeah, I'm right there with you. I think that you're seeing that how people are thinking about this. They're thinking, could she have a psychiatric disease? But it's unusual to have a psychiatric disease at this age. And so naturally, I think you'd have to think, is there a secondary psychiatric disease? And yeah, you're right. Anti-TPO is associated with steroid responsive SREAT, steroid responsive encephalitis, with autoimmune thyroid disease. Unfortunately, the prevalence of TPO antibodies are so high that all the positive result does is it says it's possible she has this disease. It's a rule-in test, not a rule-out test. It's a rule-out test, not a rule-in test. So I mean that if it's negative, you can rule it out. If it's positive, she could have it and just be a normal person and have another diagnosis like Creutzfeldt-Jakob disease, or she could have the disease. So I think, how do you make progress in this case now? You've ruled out a primary meningeal disease. So if we're sticking to the master schema right now, we're saying either she has a sub-radiological disease, and Yusuf will tell us, hey, neuroradiologist reviewed her MRI. It looked like she had cortical ribbon patterning and a lesion in the putamen, and that prompted us to check the RT quick, and that was positive, and she had a devastating disease of Creutzfeldt-Jakob disease. One thing that is a strong argument against Creutzfeldt-Jakob disease is most patients have one of these two features, either myoclonus or ataxia. And since she lacks myoclonus and ataxia, thankfully, I think that pathway is a little bit less likely, but it's so important not to forget that. So where does that leave us? That leaves us with either that she was taking a substance that is lingering in her body, keeping her confused, and there are many of these, including bismuth. So if she had some GI upset and has been chugging bismuth for a while, that might take it some time to clear. Or it's an antibody. It's hard to ignore that she has lupus, Yaz, and for me, I think the possibility of neuropsychiatric lupus looms large. And as far as I know, the antibody profile for neuropsychiatric lupus has a higher rate of anti-ribosomal P antibodies, RPP. And so I think I would probably discuss with rheumatology at this point and ask, should we send this test? But more importantly, what's left before we either given we either give her Ativan or immunosuppression. And so, yeah, I think that's a little bit tricky. The way I would do it is I would probably see if she has a dramatic response to lorazepam for the idea that she has catatonia from lupus. And if not, I think what's left is to see if she responds to empiric immunosuppression for antibody-mediated disease. So it's not meningeal, it's parenchymal. And if it's parenchymal, is it subradiologic? Probably not, because Creutzfeldt-Jakob disease is associated with myoclonus and ataxia. Is it truly subradiologic? And I think that's where antibody-mediated disease. We may never find her antibody. We may find it be linked with lupus. But I think Ativan and or immunosuppression are on the table now. What did you guys do, lupus? I said lupus. Yusuf.
I just want to say, yes, that before starting residency, I had no idea about any of the things you just talked about, like no clue. I think I learned all of these within the last year, so you should be proud of yourself. So in this case, we did go down the corticosteroid route. We were like, she had a positive TPO. Could she have a steroid responsive encephalopathy? Her TSH and her free T4 were normal. Her thyroglobulin antibody was normal. She was started on IV steroids this admission. She was hospitalized for a few days. There was no significant improvement with the steroids. Other serum workup was the B12, vitamin E, copper levels, ceruloplasmin. All of that was normal. She got an autoantibody panel on the serum, including like an APLS, a full autoantibody panel that was also negative. She was ultimately, aripiprazole was up titrated, and she was discharged with outpatient neurology follow-up. The autoimmune and paraneoplastic panels returned as negative. And I think the next aliquot will reveal the diagnosis or our best hypothesis.
All right, Yaz, what you got?
So you mentioned that after you gave her the trial of corticosteroids, she got better?
No.
So, no, she did not? Oh, no. Actually, and the anti-paraneoplastic and autoimmune panel was negative. So what leaves me there, I'm not sure if there will be any vascular issues still on our table, because, or was she still on her meds, like her initial meds while you were treating her? Because that's my last bucket I have, like any medication that she had been like taking, or I mean, I would definitely be curious to ask if she had been taking her medication correctly. Not saying like not taking it or taking it more than she needed, you know? But I am really puzzled, Rabih.
Yeah,
I was expecting this to be Hashimoto.
I mean, what are the chances that we can figure this out with certainty if Yusuf plus neurology plus rheumatology plus psychiatry plus patient's family has no clear answer? And I think all you can say is what causes MRI negative brain devastation? And the answer is it's always a molecule, be it a toxic injection, an antibody, prion disease, or catatonia. And for me, if I were this patient's family member, I would say, can we try some Ativan and see what happens? But that's the only tool I have left. I think the reason to even suspect catatonia is because it is this well-described feature of lupus and its effect on the brain. So either how can you make this patient better? Either more aggressively immunosuppress her and say steroids weren't enough, or try some lorazepam. But let's learn from Yusuf.
I didn't have an answer at the time, but I was just like reviewing the chart, and I think she followed up with neurology outpatient over the next few months. She did get a repeat MRI that was also normal. However, on their exam in neurology clinic, they did notice very subtle signs of Parkinsonism. They said that they noted a very monotonous speech, bradyphrenia, decreased eye blink, saccadic breakdown of her smooth pursuits of the eyes. Neck rigidity, but no cogwheel rigidity, and gait was slow with slightly decreased arm swing on the right compared to the left, and the reflexes were intact. So for the neurology follow-up, they were concerned. The aripiprazole was down titrated at this time. So initially they were like, could this be Parkinsonism from aripiprazole? But this was also discontinued and she still had those findings. So they were concerned about like a primary, like a Lewy body dementia or a Parkinsonism spectrum disorder. And that's the end of the case.
Fascinating. Wow. What do you think, Yaz?
I am honestly, thank you for this review. I am very grateful for this case. Definitely, I think that being able to learn how to like approach different things, like at the end of the day, it was, I think, all of you. So yeah. I thank you. I'm still trying to process.
We know, but it's amazing. You planted this possibility early on. You said, hey, I want an LP and I want to do this, I want to do that. If I don't find anything, I'm going to think of a dementia like Lewy body dementia. And I think your pathway took you to that answer, because if she had antibody-mediated encephalitis or prion disease and it was untreated, the follow-up in neurology may never have happened and she may have suffered serious consequences. So the very fact that she was able to follow up, and that Yusuf is checking her chart now years later and that she's still alive, I think is the feature of neurodegenerative diseases. And the final lesson I will impart upon you all, two lessons. The first is that 20% of what is called rapidly progressive dementia turns out to be a regular cause of dementia presenting in a more rapid way, like Lewy body dementia or frontotemporal dementia. But the biggest lesson I want all of you to take away is what Yusuf has just done, is that many of the mysteries that we think are mysteries, 2, 3, 4 years later, they're clarified in some way, shape, or form. And I think how Yusuf got clarity that she has survived and not decompensated. If she had CJD, she would be passed away from now. If she had untreated autoimmune encephalitis, presenting this seriously, she would have passed away from now. So the fact that she is alive really implicates a neurodegenerative disease. And the only way we would have known that is from Yusuf following up. So kudos to you, Yusuf. I'm really curious, before I have to go, I'd love to learn from you. What did you learn both now and at the moment from this case?
Yeah, absolutely. May I share my screen?
Yeah, go for it. Okay. Yeah, I think you're a co-host. Yeah.
Okay. So I think the way I was framing it when I saw the patient, they were calling it psychosis. And it's very interesting about the diagnosis of psychosis that gets thrown around all around, like for a lot of patients. And I think I tried to develop a framework, which I wrote 2 minutes before VMR, so literally 1 hour ago. But I think in the general framework is in all comers, you want to rule out substances, including meds, UDS. And then if it's the younger you are, the more likely it's a primary disorder, and the older you are, the more likely it's a secondary disorder. If you're young, in all patients, you want to look for an extra brain fingerprint. So this includes look at the skin, look for infections, look for seizure. Rarely it's porphyria or lupus or sarcoids, and these are young people. So you want to look for any clue, like the skin, look for, you could consider an LP or anything like that on the lung, chest x-ray, etc. And then older patients, then you might consider secondary more than primary. And that's where you look for things like autoimmune or paraneoplastic panels. There are some serologies you can send, like TPO, celiac, etc. And then rarely it's sarcoid or chronic infections that infiltrate or heavy metals. And at your disposal are actually not a lot of things. It's MRI, LP, EEG, a PAN scan, and the only thing left here are MRA and brain biopsy. So these are, I just wanted to share the schema that I just created.
That's amazing that you can create such a rich schema in 2 minutes before VMR. That's absolutely awesome. Thank you so much, Yusuf. Unfortunately, I have to head to round with my team. But I really wanted to thank you, Yaz, for an excellent discussion. It was a treat, and I'll remember this for a lifetime, my friend. Best of luck with your intern year. Thank you, David, for scribing. I think I didn't get to show you some love before we started, but really, really appreciate you scribing despite the 24-hour shift that you just came off of. Anmol, I can't wait to check out your teaching points at the end on YouTube, and big thanks to Yusuf for an awesome case. I see that I just saw the chat now that Jeffrey's been peppering us with amazing lupus plus brain pearls. So Jeffrey, this is a petition for a rapid fire session about lupus in the brain at some point in the future. I'd love to learn from you. All right, so Yusuf, maybe I'll make you co-host, and I'll make you the host, and happy teaching points. Anmol.
Thank you for the wonderful case and the great discussion. We will now just briefly go over the teaching points. The patient came to us with the complaints of change in personality, and we decided that we need to differentiate it from altered mental status. So altered mental status is basically change in the level of arousal, and change in personality seems more focal, whereas altered mental status seems more diffuse nature of a problem. So our questions were, what is meant by change in personality here? Like, what are the characteristic features, and what is the time of onset of symptoms? Then we realized that the patient was having a subacute nature of change in personality, which made us think of dementia. And we thought of characterizing what type of dementia is there. Based on the risk factors, we were considering vascular dementia to be one of the possibilities. And also the drug history was important to see if any drug is responsible for causing any dyselectrolytemia or any changes to the brain causing the symptoms, and also the drug-drug interactions are important to note. So the next we were discussing that the patient had a vast past medical history. So what could be the complications for that? The patient had lupus. So the lupus patients can develop psychosis or catatonia, and an indirect complication can include TTP. The symptoms of the patient made us localize the problem to either frontal lobe or temporal lobe or basal ganglia. So there was a question to actually to do the imaging of the brain. So how to decide between CT and MRI? CT is mostly done where we are convinced that the issue is in extraparenchymal space, or it's hydrocephalus. So basically, CT is done to look for herniation, hydrocephalus, and hemorrhage. And MRI we can do without contrast and with contrast. Without contrast can be done if we are worried about stroke, and with contrast for all the other things. But if in this patient CT and MRI both were normal. So next we wanted to rule out meningeal disease. For that, lumbar puncture was one of the plans. And the other possibility was subradiologic parenchymal disease, which could have antibodies, catatonia, or prion disease as a possibility. So we can reassess MRI for that. The patient was found to be having high TPO. Then we thought about Hashimoto's encephalopathy as one of the possibilities as well. And lupus, a possibility that lupus is causing high TPO was also kept. Next, we were also thinking about to diagnose the patient based on the response to treatment. So the last point was what could cause MRI negative brain devastation. The possibilities were toxin, antibody, prion disease, catatonia, which is a well-described feature of lupus. So we were discussing that we can try lorazepam in this patient to understand if this is the cause. Ultimately, we found that the patient was actually having dementia, and the type of dementia could be possibly Parkinson-related or Lewy body dementia. So there was a lot to learn from this, a very real-life-based case. So thank you so much for all the learning. Thanks a lot.
Thank you so much, Anmol, for the excellent teaching points. And I just want to remind everyone that if you want to present a case, you can sign up online on this website, on our website. And if you don't have a case and are interested in presenting, you can just write, I'm interested, but I don't have a case. We can provide you with a case. And people who present frequently are asked to join the team. And then you're part of the community that's very, very active and all over the world. And it's very fun. So thank you all, and hope you all have a wonderful day.